Hello, everyone, and thank you for joining us for this important session on sustainable solutions for expanding and empowering the female health workforce and women entrepreneurs with a focus on midwives. It's my pleasure to introduce Dr. John Nkengasong, Director of Africa CDC. And we'd also like to congratulate him on being named Time's 100 Most Influential People of 2021. So Dr. Nkengasong, with no further ado, we'd like to really, you've been doing an amazing job and saving lives in the African continent. You've faced a lot of challenges in the battle against COVID-19. And I know that you've remarked that it's time for action in growing the health workforce, and that there are medicines, vaccines, and diagnostic testing that are necessary. What do you see as a role for specific members, in terms of the different sectors to help with female health workforce, specifically such as it pertains to midwives?
Okay, good. Thank you. I was struggling, John, with my videos. Greetings, unusually from Rome, not Addis Ababa, where I'm here at the Global Health meeting on pandemics and public health at the Vatican and discussing inequities. I thought I should start there because of the profound nature of the discussion we are having this morning or this afternoon, depending where you are. But let me first of all really appreciate this long-standing collaboration and really trusting relationship between the Africa CDC and the Global Health and Development. The Global Health and Development believed in Africa CDC 5 years ago. The concept at that time, it was still a concept before the organization actually believed in itself. I remember Joanne and I running the hallways of the World Health Assembly in Geneva and other meetings in Washington, just putting our heads together on how do we move this very important concept, a vision and the wisdom of the head of states of the continent forward. Today, we are at a very different place. About 5 years into the creation of Africa CDC, it has earned the respect of the political leadership of the continent. It has earned the respect of the global health community and has earned the respect of member states. For that, I'm truly grateful for the various partnerships, including some of you or most of you who are on this call today. I think the continent as a whole is going through a pivotal point because of its integration agenda. Africa is moving forward with its Agenda 2063, which aims to integrate the continent more and at the same time bring developmental opportunities on the continent, like the Continental Free Trade Agreement. That is very important for the development of the continent. But that is challenged by a burden of diseases on the continent. We've all said that Africa bears a substantial burden of diseases, and it can very simply divide that into 3 pockets, what I call the syndemics. One is the emerging and re-emerging infectious diseases. That is the Ebolas that about 3-4 years ago, we were struggling with Ebola and we thought we got it under control, not knowing that perhaps Ebola was a signal that something big was going to come, and that something big is COVID, and who knows what is going to follow. The second pocket of diseases that we're dealing with on the continent are the more traditional endemic diseases, some of them pandemics that have translated themselves into endemic diseases. For example, the HIV/AIDS, TB, malaria, and then the non-communicable diseases, which are rising significantly together with maternal child health and immunization programs. That is the challenge that we have in a very nutshell. We face this challenge against a very fast growing population. We are 1.3 billion today, projected to be 2.5 billion in the next 30 years. And in that scenario, 1 in every 4 human beings on Earth will be an African. We are also seeing a change in dynamics of the urban population and the rural population. It used to be that the continent was more rural. Now you're seeing more people in urban cities, and that is creating a feeding into the endemics there. So where do we go from here? Back to the topic we are dealing with here, which is the critical role of midwives. I think it is fair to say that in my 30 years experience in public health, midwives and nurses and community healthcare workers, I would bring them all together, truly the nexus in the community between global health security and universal health coverage, or primary health care. I prefer actually to use the word primary health care because it is what it is. If we do not get primary health care right, then of course we cannot aspire to get universal health coverage. So the midwives play a critical role in that interface. And if we support that well and strengthen that component of the health system, then we are directly addressing the three syndemics that I mentioned, i.e. immunization programs, emerging diseases, and the endemic diseases. It is amazing how all three are very related. I mean, and COVID has taught us just how interconnected we are and just how vulnerable we are, regardless of whether we live in the global north or the global south, and has further exposed the inequities that exist, whether we're dealing within a country, between countries, or between regions, and more globally. Africa faces a unique challenge in terms of healthcare workers. As a continent of 1.3 billion, we only currently have about 3 million healthcare workers, including the midwives that are a subset of this. That is a staggering number. And we know that these people bring trust to the community, that we have to begin to look at healthcare from a patient-centered approach, which means we aim to treat the individual and not just the disease. And the people that serve us, the interface between high-level clinical care and the patient, will be the midwives going forward. So be using their trust capital to address these inequities that exist and to address the syndemics that I just highlighted. Because at every given moment, it is not uncommon to see someone who is HIV positive, TB positive, and also has COVID, and maybe will have an episode of malaria. So you have to look at this person from that perspective of an ecosystem, that you are treating the patient and not just the disease. Treating the disease will mean you go pick their antiretroviral therapy and then they walk away, or their TB medication, but that is not what, I mean, it is that I'm referring to. I'm really calling for or focusing the centrality of what midwives can do in this scenario, and with an acute shortage of that. So let me speak a little bit on the inequities on the vaccine access that we are dealing with today, which is the greatest challenge. That is, COVID, in my view, is the greatest challenge of our times now. As a continent, we have immunized fully only about 4% of our population, out of a population of 1.3 billion. When we set our targets last year, that we were striving to immunize at least 60% of the population, we were literally ridiculed that you never, I mean, there's no point trying to vaccinate 60% of the population. I'm very delighted, however, that with a change in mindset, where we are all now saying we need to vaccinate almost 60% of the world's population before we get rid of this. So we are very pleased. We welcome those change in targets. But it's very important to understand, in order to understand where we are heading, to appreciate where we are. Today, as we speak, 4% of our population have received 2 doses of vaccines. 6% have received at least 1 dose of vaccines. I think that is the landscape we are dealing with. If the people that fought the pandemic in 2018 were to be brought back today, they will be watching us with total, they'll be awed. They will be very, very encouraged. They will be amazed by the progress that science has brought to this modern pandemic. These are people who fought the pandemic in 1918 without knowing what they were dealing with. Remember, the virus was only finally identified in 1930 when the pandemic was over. They will be amazed and by how smart science have evolved. But they will also be very surprised by the fact that we have the tools in our hands, but it has deliberately escaped our ability to act collectively, act in the spirit of solidarity and cooperation, so that we immunize at scale and at speed across the world, and not just some people. In Africa, we are faced with 2 challenges of vaccination. One is how do you roll out vaccination in the community? And second is how do we expand testing? And this is the unique role where I see midwives playing a very critical role in those two components. I bring in testing here because the testing is the central, the centrality of good public health is testing. And I think we have not emphasized that enough. And we know that to get from 4% vaccine coverage to 70% will take a while. So we need to enhance our testing in the community. And that is why nurses midwives will be extremely important in advancing the testing agenda and scaling that up. Midwives will also be very critical in the uptake of vaccines, where trust is so important. That's why I started up earlier by highlighting the critical role of trust and the role the midwives play in that space there. It's a very dynamic and fluid situation on the continent. I keep saying that the future of COVID in Africa is unpredictable and uncertain because of access to vaccines. And even if when vaccines are there are certain communities that we need to work very hard on them in order to for them to accept vaccines. And the only people that bring the trust capital to bear will be the community health workers and the midwives. So I think this is very, very important. Let me just conclude by sharing a few remarks on where do we go from here. I think the first thing is, as a continent, in order to guarantee its health security, we need to embrace a new public health order. The first ingredient in that new public health order is workforce development. Workforce development at several levels: epidemiologists, laboratory, midwives, community health workers. We need to look at them all in a holistic manner as if we are going to war, because we truly don't know what is at the corner. We don't know that the next time around we are hit, we will be hit by a virus with a case fatality rate of only 2.5%. It could be hit with a virus with a case fatality rate as bad as Ebola, okay, and it will be devastating there. So having a competent workforce with midwives at the center will be critical. Second is our own institutions. We need to strengthen infrastructure. The midwives must be able to operate in settings, infrastructure that is adequate, that is enabling, so that they can take care of and treat patients, as I described earlier, from a patient-centered approach. Don't just treat the disease, but treat the patient. Thirdly is we need to focus on manufacturing basic tools, what I call the trinity of countermeasures, medical countermeasures, i.e. vaccines, diagnostics, and therapeutics on the continent, so that the next time we face with another pandemic, they are originally produced and distributed. It will be for everybody's interest for this to happen. And lastly, partnerships. Partnerships such as the ones that we are discussing here today, we call it trusted partnership for impact. It's what we need for the continent, so that it's coordinated by a body like the Africa CDC that has the regional respect, ownership by the head of states, and can help drive these initiatives forward. So thank you again, Joan, for including Africa CDC as part of this dialogue, and I will be happy to discuss this further during this conversation.
Thank you, John, and thank you for your amazing leadership on the continent, and also your resilience through the past 5 years. As you mentioned, it was early on 5 years ago where this crusade started. So thank you for your continued leadership for the past 5 years in a time where more than ever we've needed it for the past 18 months. And so with that, I'd like to turn it over to the speakers framing our discussion, and then also get a little bit more input back from John. So if you don't mind, I know that you have important meetings in Rome, but we'll keep you.
No, I'm fine. I'm fine for now. I think we have reserved, I've told the meeting that we reserve an hour for this conversation.
Right. So Phyllis, I'd like to turn it over to you, as head of social impact and also CEO of the UBS Optimus Foundation. John has provided such excellent framing in terms of, the health workforce and what's needed right now, especially under a pandemic, and the need for midwives, really. And as we're dealing with the African heads of state, as he mentioned, in this health workforce initiative, we need women more than ever. And as we move to strengthen both financial, health, and educational system, it's been encouraging to see such a concentrated effort in development finance to mobilize capital to support education and female entrepreneurship. like to get your thoughts on, how we can do even more to support workforce training for women and support female entrepreneurship.
Thank you very much, Joanne. Thank you for having me, and thanks to all of you who are listening in right now. And as we just heard, and as we all know, this pandemic has had a huge impact on societies globally and more so in developing countries. And these are all new problems, and we're going to need new tools to address them. The economic shocks also from COVID mean that progress on issues like healthcare, workforce training, midwives are going to rely on increased government and philanthropic support, even as pressure intensifies to cut development budgets, and we're seeing that across the globe. So that means we have to work smarter. And I strongly believe that results-based funding and blended finance will be an increasingly large part of the solution. The bar is rising, and as funding dries up, governments and funders are going to rigorously assess programs to see what works and what doesn't, and to make sure that the funding that we're putting in place is actually working effectively. And so we'll need new approaches that are going to leverage social capital to attract private capital if we want to have any hopes of achieving the SDGs, and particularly SDG 3, and particularly for women healthcare workers. And I'm very lucky to lead an organization, UBS Optimist Foundation, that's pioneered some of these new approaches. And our experience shows that results-based funding can lead to better and more cost-effective outcomes. So instead of paying for activities without the guarantee of success, results-based funding puts an emphasis on specific and measurable outcomes, which then lead to a payment. And I'd like to highlight one example that the UBS Optimist Foundation has run for the past 3 years, along with our partners in India, which is called the Utkrishт Development Impact Bond. And that's a form of results-based finance that's benefited over 300,000 pregnant rural women in Rajasthan by improving maternal and newborn health care. And we provided the investment funding, and USAID and Merck for Mothers are paying for outcomes as healthcare facilities improve the quality of their services. And paradigms like this are ready to go to scale. And blending philanthropic and commercial capital to improve healthcare, environment, and education I think we're going to see a lot more of this. And blended finance using catalytic capital from public or philanthropic sources to increase private sector investment in sustainable development is one promising route. And enough private wealth exists, as we all know, and that has grown substantially over the past 2 years, has tremendous potential to help bridge the funding gap that we're experiencing. So we need new tools now more than ever to address some of the world's most pressing problems, including the woeful state of some of our healthcare systems. And this isn't going to be solved alone by just government funding and philanthropic capital that's currently in play. We really need to find new sources of funding. Thank you.
Thank you, Phyllis. And I see some of our women philanthropists, heads of social impact firms nodding, and then also the live stream just blew up on my phone on that. So thank you so much. And married with John's comments, I think it is a perfect marriage of how we can deploy sustainable solutions on the ground. But we'd like, thank you, Phyllis, and we'll come back to you in terms of that. But I'd like to take your comments on that results-based financing, because we do want to get practical in terms of the implementation, right? How do we move to provide more financial resources for those midwives, in the continent of Africa? How do we move to increase those women entrepreneurs? And I know also that Crown Agents and Fergus Drake, as CEO of Crown Agents, was tasked with the amazing mission of taking on a results-based financing project overnight in almost the whole country. And I think we want to be able to take from some of those lessons learned as we begin to deploy some of the packages of care in terms of implementation, possibly for midwifery in Africa. And then also just what we learned from financing, right? Is it doing anything, right? Is it incentivizing? I mean, not only do we need additional funding for midwives, but we need the right mechanisms and models to deploy in some of the countries where we want to move ahead. So over to you, Fergus, to just kind of give us a little bit of overview with that vast implementation that you did recently in Zimbabwe. And we'll get into more specifics later on in the session, but if you could comment on that, that would be great.
Wonderful. Well, thank you ever so much, Joanne, for having me. And it's humbling to be sharing a webinar with Dr. John and everything he's achieved with the African CDC. And I completely agree with all of his comments about vaccine inequity. We at Crown Agents have been very involved with that as well. And it's obviously shocking what we're seeing around the world. But I think I just wanted to put a bit of flavor around it and share an example like Phyllis just did. We've been running a results-based financing program in Zimbabwe for the last 7 years. It has funding from the EU, Ireland, Sweden, Gavi, and the UK government, with funding then channeled through us through UNICEF. And in essence, we contract not-for-profit health facilities, district hospitals, community-based organizations to deliver specific services. We then verify those services through both quantitative and qualitative indicators, and then make payments on those contracts. We then build separately the Ministry of Health capacity and the respective health facilities, and have ongoing evaluation mechanisms. So you talked, Joanne, about scale. So we reach 848 primary healthcare units, 67 hospitals, and 42 rural districts. So that's reaching 6.6 million people across Zimbabwe. In terms of impact, 130,000 more women now are receiving antenatal care services per year than at the start of the program back in 2015. There's been a 180% increase over 3 years in women attending health facilities. There's been over 5.5 million postnatal growth monitoring visits, and we've obviously worked with the data management expertise of those 850 healthcare facilities as well. Headline mortality has dropped from 651 deaths per 100,000 to 462 per 100,000. Obviously, our program is not the sole indicator of that, but we have made a difference. So you talked about learnings, and I went back to the team and said, if we were bottling this again, if we were replicating it, because I do think it is very replicable, what have we learned? And the first one is incentives need to be big enough to both improve service provision and the quality of care, and have to be large enough to actually make a difference. And they need to be incentives, not a replacement for the actual salary for the community health worker. There needs to be strong local decision-making and strong community engagement, and that's absolutely key for sustainability. So our model empowers communities to make the judgments as to where those incentive payments then go. Data needs to be fast and reliable. So we use mobile handheld apps, which means we can get that qualitative and quantitative indicators within hours, that then leads to payments that used to take months and months and now take days. And there does need to be that culture of continued improvement. And so that we've shown with a good foundation, you can not only improve the health infrastructure, but the community health workers and the nurses' capability themselves that Dr. John was talking about. And then the last point is that if you get this right, you then get into an upwards virtuous circle of continual improvements, whereby funding is being released quickly to those primary healthcare units that are actually having the biggest impact on the health indicators, but again, across qualitative and quantitative indicators. So that package has been a long journey. That's over the last 7 years in a challenging operational environment that Zimbabwe is. But we do feel that there's enough data on it now, and the key inputs from donors, blended finance that Phyllis was talking about, as well as obviously the Ministry of Health, for this to be able to be rolled up and put to scale across the continent.
So Fergus, we'll definitely come back for you because KPIs as we're deploying midwifery programs and, on the ground will be key to, a lot of, future, funding and how it is deployed. And I think, John, I don't want to speak for John, but I think, a lot of what's needed also within the increases of midwives is having the modeling to track how that's being deployed on the ground. So I'd like to turn it over to to Ikuyu, because I want to come back to the speakers for a brief second for a comment. And I know that Ikuyu, you're Deputy Director General of Human Development Department of JICA, and you commented on the importance of local, homegrown solutions and also having the partnerships between the government and the private sector. And so I'd like to comment on some of the programs you're deploying right now in Africa in terms of how you ensure alignment of operational strategies and desired outcomes, and what steps maybe the partners here, all the multi-sectoral partners can take to ensure that these efforts are in sync and moving towards the same goal.
Thank you. Thank you. First of all, thank you very much for inviting me to participate in this excellent panel of speakers. And we are really delighted to, or excited to learn, and also, see what is going to come out from this dialogue. I think COVID-19 revealed many shortcomings in the global readiness against health emergency, and one of them was definitely the global supply chain of essential medical supplies, including PPEs, which is really needed by the frontline health workers to protect their own health from the risk of infections while providing the services. And also, there's the challenge of international supply of expertise because of the travel restrictions. That's why, even though I am a strong believer of solidarity, the concept of a local solution or homegrown solution is really needed to make Africa, or this is not only Africa problem, but globally, the resilient against the health emergency, the threat coming from the infectious diseases and other threats. And JICA has long supported the local solution working with the public sector in the past, like a community health officers program in Ghana, CHIPS, working in CHIPS, and also the village health midwives in Sudan. They are really the frontline workers, and then we are really thankful that even during the time of pandemic, they are at the front line of service provision, as well as the only, maybe in many parts of the localities, they are the only source of reliable information as well. So I think their role is really important, and I think we need to continue to invest on their capacity development as, for the time to come. But we are also increasingly working with the private and business sector to promote a local solution. One of such example, which is coming out as a result of our, that one part of our COVID-19 response, is a partnership with the AU Development Agency, NEPAD, and Boston Consulting Group. We call it a Homegrown Solution Accelerator, where we invite African healthcare companies with the potential to make impact on the health of the vulnerable people and who are willing to go scale. And we provide tailored support such as context-specific advisory and access to affordable capital, regulatory and trade facilitation and matching to the strategic partners. And one of the cohort of 5 companies selected out of 56 applicants from East African community is Access Afia from Kenya, who is providing affordable healthcare to poor neighborhoods through the network of 15 clinics in Nairobi. And they're focusing on employing staff from the local communities. And 60% of their employees are women. And they have a plan to double the scale of their operation and go beyond Kenya. And their operation will have a health impact on the community as well as more job opportunities, especially for women. And also the vibrant private sector can provide employment opportunities for female health workers as well, particularly in countries like Kenya, where qualified healthcare workers are produced more than public sector can employ. So our role in this program is not limited to ensuring access to knowledge and capital. Through the consultation with the initial cohort companies, it is really apparent that many of them face regulatory challenges dealing with the government regulations. And since we have a strong relationship with the public stakeholders like Ministry of Health or the regulatory agencies, we may be able to facilitate the local solution from which may be hindering the local solution to take off and grow. So I think the partnership like this can really have important role to play, both from the business sector as well as the private sector, so that really the local, the homegrown solutions to take off. So I'm really looking forward to working with you all in our field operations. Thank you very much.
Thanks so much. And we're looking forward to the deployment, and we will, be turning over to experts, such as John for the, local deployment of Africa CDC, and to Fran. But I'd like to, before we get into that discussion, just quickly jump in and have Harold comment, because I know in terms of a lot of the access programs that have been going on, at Gilead, Dr. Nasser oversees, over 130 countries. And I know in the efforts to include engagement of critical stakeholders to ensure access, there's been a lot of success. And so it'd be great to get your thoughts in terms of some of those critical stakeholders as we're moving forward, because from this session, as a lot of you have been socialized, we will be moving quickly to deployment. From now, we will launch that informal advisory group, and then we will work with the partners to not only scale the number of midwives, but also look in terms of those programs for female entrepreneurship that need to become part of the sustainable solution. So this session is a means to an end. As I've talked to many of you we are moving quickly to implementation. It's not just a session. We just will work with each of you after this to make sure we're deploying into next steps. So Harold, over to you. You have a diverse, crowd here of critical stakeholders that can engage in vast experience in how you deploy access to care. So it'd be great to get, your perspective on working with these partners and specific steps that we may take to even engage governments to ensure that there's political support for these efforts.
Thank you, Joanne, and thanks everybody for entertaining in this discussion. My name is Harald Nusser. I've joined Gilead in May this year to head up global patient solutions for Gilead, and we have a dual responsibility. On one hand, we are part of the commercial organization, so we need to basically provide the funds through own operations that we can invest into health system strengthening according to the 6 building blocks of WHO. John has basically said everything, so I will be very brief. I don't need to repeat this. Integrated, decentralized care. We treat people, or we should reach out to people, not consider only diseases. Prevention is providing the biggest bang for the social bang for the dollar invested, and decentralized care is of course centered around primary healthcare service delivery and also the ability and the government support for community health workers or midwives to also initiate interventions. When it comes to community health workers and midwives especially, the big question is not only how to train them and scale their number, but also how to retain them. And that links to sustainable business models also for the community health workers. And the experience I've made also in my earlier roles in the industry is that, of course, living goods is a very famous example originating in Uganda. But even they have not completely managed to make their engagements really financially independent from donors, because that's ultimately the goal for me. Not to superimpose solutions, not to just donate and be active with philanthropy, but to help enable communities and countries to take care of their people. In my previous role, we had country engagements where we invested $1. With that dollar, we reached 3 people of course at higher scale, but broken down. $1 invested, 3 people reached, and we've earned that dollar back. For me, this is an experience I would gladly be willing to share, and it's a model that can be replicated and could also be scaled. So, what is the role of the private sector? It can and must be catalytic, working within the system towards the 6 building blocks as defined by WHO. We can inform about sustainable models and entrepreneurship. What would it take for female health workers to have an independent income? And we are innovative. We are innovative also in the sense that we can spot opportunities maybe at the adjacency of our core business interest. For example, when it comes to point of care testing, viral load determination within 20 minutes at the point of care with an affordable device, and doing this jointly for several diseases. Therefore, integrating not only service provision, but also integrating diagnostic capabilities. We can't do this on our own, but we can help identify those organizations and help them grow and scale. And this example actually exists. And this brings me back to the integration of care, not only integrated point of care testing and determination of viral load, but also engaging early in order to prevent vertical transmission of HIV, syphilis, and HBV, for example. And that automatically yields a priority, which is triple prevention of mother-to-child transmission. This as a prevention is the right method to engage. It is integrated and based at the community. And last but not least, it's linked to Gilead's experiences in virology. Thank you.
Thank you, Harold. And we look forward to, as you said, working from technical assistance, to sustainability. And I think that's where, at different levels, you have partners around the room that can, focus on those many perspectives as we're deploying solutions for midwives in Africa. And I'd like to turn it over to Dr. Anshu in terms of, WHO has undertaken, some analysis over the years on the impact gaps in health workforce and delivering primary care, including specific needs and opportunities. And I know that you're going to deploy a toolkit. So how do we collectively address some of the key bottlenecks and intersections? Harold spoke about the private sector and the need to move from technical assistance also, to sustainability. We've focused on the continent with John and the local expertise, Crown Agents and Phyllis talking about results-based financing, and Ikuyu talking about that private-public partnership. So how do we, overcome some of those bottlenecks that you found and move to, the implementation that you're looking at both at the toolkit and also increasing the number of midwives?
Thanks, Joanne. And maybe the first thing to highlight is really that WHO is an intergovernmental organization, and therefore we are a member state organization in a way. And we work very closely with national governments, and for us in particularly Ministry of Health, but also with other ministries like Human Resources, etc. And this allows us therefore really to support national plans and to support governments to develop their national plans in line with the SDGs and to identify the targets that they need to achieve in order to attain the Sustainable Development Goals by 2030. And our current work around private sector engagement is really to strengthen the capacity within governments, within the Ministry of Health, to engage with civil society and with private sector in order to, for the private sector to actually support the goals of the government. So this is the framework they're working with. The other thing is, as you highlighted, and as many speakers have highlighted, really partnership. I think it's very important to work with government in partnership. We have, for example, come out with a report earlier this year around the State of the World Midwifery Report, highlighting that there is a gap of 900,000 midwives globally in order to achieve the SDG objectives. And that it's also very important to highlight that they actually deliver, not only, midwives don't only do deliveries, but they actually provide around 50 different services within the area of mother and child health and primary healthcare. And so it's really important to strengthen this capacity at country level in order to achieve primary healthcare goals, and to make sure that through these investments that we are talking about, we can bring this to scale. I think, as Harold said, bringing to scale is a very important issue. And we can work with governments jointly to see how they can put the right policies in place around a health workforce, around incentives, making sure that no one is left behind, and that we have the right health workforce in those remote areas where at the moment we have major gaps.
Thank you so much. And I'd just like to take a quick moment, Dr. Nkengasong, and get your input on, some of the solutions that, have been proposed by some of the partners in terms of, those increases and, and also, as discussed earlier, some of the partners, have willfully joined, a next step in terms of, an informal advisory committee to scale the number of midwives. So just trying to get your reactions. And I know you have the Head of State Health Workforce Initiative, WHO is going to talk about later the toolkit, but how do we really, formulate next steps to increasing the number of female health workforce? I know you're at the head of state level with the health workforce, but the female health workforce and midwives specifically. Oh, John, you're on mute.
And you think probably you've done this for, all of us have done this for 2 years, you know that you have to unmute before you talk. So let me agree with what Phyllis said earlier. I'm mentioning the need for new tools. New scenarios demand new tools and new ways of thinking. And we should seize the momentum. I think my short answer would be seize the momentum, let's run with it. At least in Africa, there is, before COVID, the recognition at the head of states level that we needed to expand our community healthcare workers program. And of course, a vast majority of that are usually the female workforce, healthcare workforce and midwives. So I think the point and the reason I bring that up is that you already have a political platform where you can hang this kind of initiative on. So you don't need to create anything, which you can reference. We can reference that and move that forward. And I also I like to say that Equal, it's good to see you. I mean, I've not seen you for a while. That is what pandemics do. I think we used to see each other more regularly, either in Tokyo or Addis Ababa, but now we're all hiding behind our screens. I hope that this kind of discussions will bring solutions so that we can begin to get the human warmth, which is so we are created to be human beings that talk to each other in person, not through internet. So, John, I think 3 things. Reflection here is that how do we create action-oriented partnerships so that and create the momentum and not wait for any other formal meetings. Let meetings not lead to other meetings. What do I mean by this? It will be very good to see that this group, we emerge from this saying, look, we have 3 countries or 4 that we want to action on. We all coalesce around those and then use COVID, which is, to me, an existential threat for the continent as a platform to unify, let COVID, instead of dividing us, unify us so that we all come together and address the issues in a couple of countries. And we, again, trust me, all member states, all 55 member states are member states of the African Union. So it doesn't really matter to me. So we take a few countries, concentrate there, engage with the political leadership of those countries and start doing so that it becomes, it leads to a cascading effect. And we can amplify that in other parts of the continent and use COVID as a driver in the 2 areas that I described earlier, i.e. rollout of vaccinations and rollout of testing. In the next coming weeks, we will be announcing a large initiative to scale up about testing using the rapid antigen test to about 200 million people. That way we find out where the virus is hiding, flush it before the 4th wave comes. As a continent, for the 3% of our member states are going through the 3rd wave, about 6 other countries are beginning to go to the fourth wave. And each time these waves come in, they come in with brutality. Just during the third wave, out of the 208,000 people that have died in Africa, 72,000 occurred only within the third wave. So something suggests to me that if we had a program where midwives, community healthcare workers were helping to roll out testing, you could actually empower the community to know where the virus is while waiting for vaccines. And vaccines hopefully will begin to come more frequently in the coming months. So, and it will also require community healthcare workers. Lastly, I'll say that the issue that was raised, I think Harald raised the issue about sustainability of this and predictable financing and career path for this is very, very important. We need to bring all of it together so that midwives are not only seen like we need you in times of need, and then we dispose you when we don't need you. I mean, we really need to, and I don't know the solutions to this, but it's a discussion that we need to put on the table and say, if we train, how do we retain them? And how do we incentivize and enable their working conditions there? Thank you.
Thank you, John. And I think you've volunteered to be an active member leading us, right, in some of that, modeling for the informal advisory group. And on that, I think that, we need some of the, as John said, to identify the countries and move forward quickly so that, we can deploy what's needed and the solutions on the ground. And I'd like to, just turn over to Megan quickly, because I know that some of what we need is also investment, right, in the women entrepreneurs, because as John said, we need more midwives and we need to pay those midwives, right? Because frequently when the center is dealing with some of the development finance institutions, like I've spoken to many of you in the past, the midwives are there, but they're not either getting paid to the, what they need to get paid to get on that bus, or and see their patient, or just they're not getting paid at all. And so I think, we need creative thinking and solutions of how to address those issues. So Megan, I know you've been investing a lot in women local businesses and really, the financial power of investing in women is so critical right now. So if you can just, give us just a little bit of an overview on some of the investments and also, we recruited you last week in terms of, helping us with that investment portfolio for Africa and really looking at those women. So over to you, Megan.
And I do think it's really interesting to think about the place of private capital. And it does go back to what Phyllis was saying before too. There's a unique opportunity to augment and accelerate the government funding availabilities out there with venture capital and private equity financing, because there is so much commoditized capital out there that's going into early stage businesses that has a very high threshold for risk. However, a lot of that capital is going into more product-driven companies, products, the picks and shovels, the infrastructure around those midwives, for example, the workforce services out there. And if we can think about it more as an ecosystem of resources to really work in tandem and provide both the products as well as those experts delivering the products, there's an opportunity to really accelerate that growth. So I'll back up a second, just share why we're interested in this space. So I manage a fund, I'm a partner in a fund called Amplify Her Ventures. We're an early stage venture capital fund based in the New York area. And we invest in early stage companies founded or led by women. And the reason for that is because of the business case for it. There is a very clear and logical opportunistic investment strategy to invest in companies founded or led by women and diverse leadership teams. In the venture capital asset class in particular, only 2 to 3% of venture dollars go to female founders every year. And that number goes up to 15% when there's a gender diverse team, but that's still a pretty small amount when you compare that with the results. And that is that 63% greater results are seen by those earliest investors in companies founded or led by women. So the financial opportunity is there for that private wealth in order to further augment, as I mentioned before, and accelerate the systems that are being financed through more public sources of capital. That's where I think the opportunities to come together. So I'm very excited to hear more about the advisory council that Joanne is putting together and the ways we can more seamlessly collaborate in implementing the technologies and the picks and shovels we're investing over here to be utilized by the service providers and the experts such as those midwives.
Thank you, Megan. We'll be working closely over the next few weeks. As you know, John has mentioned, we need countries' priorities and then deployment. So I'd like it to turn it over to Dr. Hillary. You know, we're looking for the implementers too of the faith-based organizations, you know, to be able to direct. And I know the Ugandan Protestant Medical Bureau has also done, you know, innovative solutions in terms of user fees, and has a large network in Uganda where they've applied user fees and worked with midwives in terms of that implementation. So Dr. Hillary, if you could give us a brief background. I mean, we need to work with governments, and also I know the faith-based organizations in some countries like Uganda have worked very closely, you know, with not only the government, but also using innovative financing models like Phyllis and Megan talked about. And then to John's point, in terms of the sustainability and heralds of how we, you know, sustain these initiatives over time.
Thank you very much, Joanne. We do appreciate the opportunity to share our experience and appreciate Global Health and Development for this, inviting us to this forum. Just briefly, UPMB, which is Uganda Protestant Medical Bureau, supports about 305 member facilities. And as part of the support that we do give to these facilities include health system strengthening. And specifically for this discussion, looking at a human resource for health, we do have the responsibility or the role of supporting these facilities to both recruit in meeting the norms for facility levels, and then also retain this staff, and then additionally support the area of competence for the staff that are at these facilities. I just want to mention that in line still with human resource for health and going towards midwifery care support at the facility, we recently did do a survey to look at the norms and the structures for HRH at the facilities, and we saw that about 81% was filled of the vacancies. But I just wanted to note that for the case of midwives, despite being at about 81%, for the midwives, it was at about 45%. Definitely of concern. If you look at the number of antenatal care attendances in a year, about 269,000 in the 305 facilities that we support. And this is despite having about 9.3% improvement in staffing. And so we do have a particular interest in this discussion, and we are glad that we have been allowed to share at this forum. In terms of experience and the lessons and what we are learning from these facilities, we see that to improve staffing levels, we need to look critically at how we support the recruitments, but most especially the retention of these midwives, because they play a very significant role at these facilities. We are looking at issues like working environment, looking at staffing welfare, that is very critical. A significant proportion of the facilities we support are in the rural areas, and so issues to do with staffing welfare are also critical for them. But also we know that this goes along with the job satisfaction that is required for the work to go on. We do partner with a number of institutions that are helping us to do the work that we're able to see going on. But also to mention that I think one of the things that we're seeing is human resource management being a critical area. You want to be able to monitor, look at the trends, be able to get feedback from the midwives such that you can support some of the emerging issues that are coming up in terms of retention, recruitment, and also the outcomes of care. We have had some experience in trying to address some of these challenges, and a lot of the issues that you have mentioned from the previous speakers come up. And we are working using a three-pronged approach to address these gaps, because we do want the mothers that come to these facilities to be adequately attended to, but also that we can have quality services, because you don't want the issues of workload and straining to affect the quality of the services. We are fortunate, or we should say privileged, to have about 16 training health institutions that we work with. And one of the approaches we are looking at is skilling or training of the midwives to fill some of these spaces that we have. We have worked with partners to provide scholarships to these institutions to bring in more midwives, and we are leaning so much to the midwives because we realize we need to fill this gap. And what we are doing is having them bonded, and so when they come out of school, they are able to support these facilities. And for these facilities, these training institutions, we do work closely with them, and we are able to provide technical support. We're also supporting infrastructure and equipment, IT connection for learning, and feedback. And so they're able to work with mentors and trainers, even in service. And so very critically, we are looking at also building up a pool of mentors and coaches from higher level facilities, but also the district local governments, and also with support from Ministry of Health, be able to keep that interaction going on. And as we do this, we are monitoring closely to see what are some of the issues, the challenges that come up, but also improvements and lessons that we're learning from these facilities. The third area that we are looking at is looking at how do we support these facilities, staff through social models for entrepreneurship, because like I mentioned, you have a number of them in the rural areas, and then issues of staff welfare, and we're asking ourselves, how do we support these health workers? We've had a lot of experience with RBF, especially in our West Nile regions, and then another southern region called Rwenzori, and looked at how this can be an incentive for the facility, but specifically for the midwife, to be able to stay and be able to focus on their work and provide care to the mothers that are coming to the facilities. So in a nutshell, really, we are looking at pre-service training, we are looking at in-service training, but also equipping these institutions with the materials that they need to offer this training, and then also ensuring that they have the appropriate skills to manage institutions. So we're having the right quality of service providers coming out. But I must also mention, we are focusing also on the HRH management to make sure that our staff that are in the facility are growing in their skills, but also in their ability to respond to emerging needs. There's been a lot of talk about the COVID pandemic, and indeed in Uganda, we were significantly affected. And then we're asking ourselves, how do we prepare our workforce to be able to respond to this need, but also to respond to out of facility support in the communities. In Uganda, we're trying a lot to build community health services, because we realize, especially when you have times of lockdown and the mothers are not able to move, how do we take services to them? But also those that need to move, how do we coordinate them to make sure that they're able to come to the facilities for services? Thank you very much, Joan.
Thank you. And before we dive into those case studies to kind of move us into our vertical pillars of, next steps, John, just turn it back to you in terms of, I know you've been working closely with the faith-based organizations and also, training and the integration of how you see this with some of the midwifery programs, as Dr. Hillary talked about with working with the faith-based networks.
I think Dr. Hillary's comments were very insightful as they touch on the workforce environment and welfare and of course the faith-based. The faith-based organizations, according to our own records and statistics, account for at times up to about 60 to 70% of facilities that people have to go to look for care, because they are in very, they have presence in very difficult areas, and they provide quality care. To me, they epitomize what I describe as a patient-centered approach, where you take care of the patient and not necessarily the disease. So I think that is very bad. How do we integrate that? I mean, move that forward. I think that is where the partnership comes in, where we cannot leave this in the public realm. It will not work. In my previous years in PEPFAR, we've developed several public-private partnerships, like with the Becton Dickinson, with Siemens, with Roche, and they were very productive and very, very productive. BD. So those are kind of partnerships that we need to bring to the table, where it's not necessarily bringing money to the table, but bringing resources, assets that can help with moving the midwife program forward. It could be in areas of capacity building and training, working with NGOs to support government, working with NGOs to support the faith-based organizations. So we just have to be creative. I really still like what Phyllis said about new tools, and I'll expand that to also include new thinking. Okay, we have to deploy new thinking and in addressing new challenges that emerge. So it requires a series of dialogues. If our end goal is to have ownership and sustainability, it requires initial dialogues. The task force that you just mentioned here needs to take upon itself to begin some very high level engagement, find champions that will, at the country level, people like Hillary and others that can actually bridge this gap between the high level discussions and what really happens in the field. And will also be determinant in looking for early wins. Okay, I think working in Africa for the last decades, I mean, the whole concept of show me what this program has done is very important. And the earlier you show that we can do certain things collectively and create an impact, it becomes a cascading effect. So innovation in our thinking is what the point I'm struggling to make here. That is just key in these challenging times. We want to believe that if we bring ourselves together as a collective, the midwife program can actually take off in certain number of countries.
Thank you, John. And we look forward to working with you in your many roles. And Phyllis, just quickly, as before we move to the case studies, as John was saying, that working with both, the midwives and the community health workers, and I'm just going to give our beginning panelists just a chance to comment on that quickly, but before we, get specific into the case studies. How do you see that, moving forward based on what the panelists have discussed, to compensate both the midwives, but then also, in terms of those, financial results-based financing and moving that work forward, and also from this session?
Thank you very much. And, we all know that supporting education and health is really the best way to support female entrepreneurs. And, I fully agree that we could do more to professionalize things like midwives, community healthcare workforce globally. And that's largely comprised of women. And they've been really the essential pillar in educating communities about COVID-19 prevention, vaccinations, and ensuring essential health services continue to function during lockdowns. And, this is largely about supporting women health workers to get the rights, supporting condition, pay, and recognition that they deserve. And all of this is very conducive to results-based financing, because this is stuff that's very easy to measure. We already know the science behind it. We know how much this improves the health of communities by supporting female healthcare workers. And it's just something we need to put more resources behind, and we're very supportive. And in fact, we are going to be launching soon a new vehicle, results-based financing mechanism to do just this. So thank you.
Great. Thanks, Phyllis, and we look forward to working with you. And I just like to get specific before we go back to our, Fergus and Harold. And I know, Fran, you've been working on a toolkit with the government, in Uganda. It started in Pakistan. Some of the, members were part of the Pakistan. And so if you could talk a little bit, we talked about the training, the increase in resources for the midwives, but just a little bit on that toolkit and how that could be a tool in its end to train, maybe give more business skills even to the to the women in.
Thanks very much, Joanne. I have to say I'm really enjoying this focus on midwives in this call, having been a midwife and worked in many countries for many years, and it is a real global issue. I think some of the comments that have been made today have been absolutely fantastic. And on the toolkit, it's a new solution, as we've talked about. We need that. It's a new tool, and I have to say it's highly creative. And what we felt in WHO is it's actually incredibly difficult for health workers and health educators to access information to teach and to provide care with. It would, it's surprisingly difficult. You can go into a school and you'll find an old textbook from 30 years ago or something. So, it's really hard. They want to know and they want to be empowered by knowledge. So just very briefly, we started to develop this toolkit led by WHO, but we are working with UNFPA, ICM, UNICEF, JPIGO. Many partners are on our various technical advisory groups. It is for in-service because we feel we really need to get those educators and those who haven't perhaps qualified 30 years ago, haven't had a single bit of updated information since, or qualified a couple of years ago and really weren't up to speed. So it can be used for pre-service. It is for adults. So there are learner guides as well as the facilitator guides. We're not hiding anything from anybody. We always start with a teamwork activity. I think, John, you mentioned that. We have to get over these hierarchies of power. We all need to work together as a team to save the lives of women and newborns. It is highly accessible. So all these activities can be done in a classroom face-to-face or online, like in a Zoom like this. And some of them will go completely online to the WHO Academy, which is all online training. We use a mixture of these teamwork activities, something called treasure hunt, which is find the latest evidence. So what is the COVID vaccination dosage rate? Where do you give it? What is the right thing to do for PMTCT? How do we best give antenatal care, etc.? We have videos that they watch and analyze. We have what we call a point of care quality improvement activity. And they say, well, we just can't have companions at birth here, although we know they reduce problems and women have better births when there is a companion. And we say, that's your problem, what's your solution? And they develop their plans. We have a lot on respectful care, because we know women don't want to go to a facility where they think they're not going to get the type of kindness and compassionate care that they need. We have a course on leadership. And within that course, we can talk about how you run your business. And I know you'll come to it soon, Joanne, but Uganda, for example, is really unique in that for over 30 years, they've had a private midwives association. That needs a reboot, but it means those midwives are ready. The course is available to everyone. It's free to access. And talking to Ministry of Health Uganda and Olive Sentambwe from WHO Uganda, who's on this call, they really want this. It will really complement what they're doing already in other areas, particularly emergency obstetric care. But this is really how everybody should be caring right the way across all professionals for healthy women and their newborns who need family planning, sexual and reproductive health, childbirth, the whole thing. And it will show them if a problem happens, how to refer, where do you find those education materials for the complication? And really importantly, how do you refer with respect, with communication, and do it well? We know too many lives are lost in between. So we're finding very high demand everywhere for this toolkit. It keeps increasing in size because of its value. Any pilot testing has come back and the midwives have said, I have never felt so empowered. The moment I saw the link to that WHO recommendation and the whole list of recommendations, or I watched those videos and now I can access all those training videos. And we find that we have to keep them short so it doesn't take years, but they will go deeper. They're all going deeper, finding out more information. And really, it's really exciting, actually, I have to say, what's happening with this toolkit. Thanks.
Thank you, Fran. And I want to be conscious that sometimes, we give interventions or gifts without being used. And so I know Mucha, who's worked with Crown Agents and Fergus, gave us a little bit of a high level in terms of, how, we need to deploy solutions. And in Zimbabwe, which again, I'm amazed that you were turned over the country by all these donors and said, go and implement these KPIs in this results-based financing. So, Mucha, in your expertise, how could we marry maybe some of those results-based financing that you did in Zimbabwe to incentivize, different workers or partners to, either increase the number of midwives that, are deployed into Africa, maybe employ a KPI for either PMTCT or something else related to vaccination. So Mucha, if you could really, tell us how, how you incentivize those workers to provide the best care possible and also services, for those clinics, because we can't have, a tree falling and nobody hears it. We really need to both track and then make sure that it's incentivized properly so it's used.
Thank you so much. So we've had an amazing run with the RBF project in Zimbabwe. When we started with a shockingly high maternal mortality rate of over 600, which together working with other partners, we managed to reduce by 30% to over 400, which is still very high. How do we incentivize our workers? What we did in Zimbabwe, I sort of like put it down into 8 things which we did in order to incentivize the workers. The very first thing was we needed to empower the health workers and empower the community because they work hand in hand. The first thing was training. So there'd been a lot of brain drain in Zimbabwe. Most of our registered general nurses and midwives had actually left the continent for greener pastures. And what we had at the health facilities were primary care nurses who had just been picked from the communities, given some trainings, and were running the health facilities. And women were literally dying at the health facilities what these primary care nurses were watching because they had not been empowered to do deliveries, a very sad situation. So first and foremost, working with the Ministry of Health, working very closely with the Ministry of Health and Child Care, with the World Health Organization, with UNICEF and UNFPA, we rolled out a training curriculum for the primary care nurses so that in at least 60% of all the health facilities in Zimbabwe, we would have a primary care nurse who was upskilled in midwifery skills. Then the second thing which we did to incentivize these workers was to give them the tools of the trade. Simple things like thermometers, fetal heart monitors, blood pressure machines, ultrasonic machines, giving them these tools of the trade and training them in the tools of the trade and incorporating the suppliers of these equipment to provide training to the Ministry of Health technicians so that when these tools are down, they can actually go and fix them. So that was the second thing, tools of the trade. The third thing to motivate, to incentivize the health workers was we provided them with basic consumables, such as emergency obstetric medicines to attend to the women and the neonates, like things like oxytocin and misoprostol. Then the fourth thing which we did was to involve the community involvement. And we worked with civil society organizations to identify and put in place health center committees at each of the health facilities. And then the fifth thing which we actually did after all that, after providing the training and the resources, was we then contracted the health workers on the resource-based financing mechanism. and agreed on the indicators which they were supposed to deliver. Now that they were actually empowered and had the resources to deliver this, already they were incentivized. There's nothing as bad as going to work and not having the tools of the trade to work with and watch women and children die. So already they were incentivized. And then when we contracted them, the money which they actually earn after delivering on the indicators is put directly into their hands down there at the facility level. It's not put at the central level, at the median level. It's put into the hands of the midwives who are actually delivering, and it's up to them. They're empowered to decide what do they need at the facility. Is it a waiting mother's shelter? Is it new BP machines? Is it a baby scale? Is it a delivery bed? They decide what they need together with the community, the health center committee. They decide what they need and they go ahead and buy it. And then of the money which they actually earn, 25% of it, if they meet a certain threshold of quality, so they must get a quality score of 60% and above, then they can share 25% of the money they actually earn under the resource-based financing. If the quality score is below 60%, they cannot share that money. 100% of the money goes to the facility and for the upkeep and upgrading the facility. And then the seventh thing, which empowered, incentivized the health workers, is actually partnerships, because we involved the community, we involved community-based organizations, deep involvement with the Ministry of Health and Child Care, UNICEF, NFPA. So what we had, and the private sector came in, the private sector within the communities, because we told them about the RBF project. So when the health facilities actually make the annual operating plan and they decide, we need this and that and this, they share with the private sector within the community, who then come in to assist them. So because they have all these partners interested and focused on the health facility, and the health workers actually know that, it also incentivizes them to work and produce because they know they're under scrutiny. And then the final thing was the providing feedback in the form of reports, and we developed an RBF booklet where we'd actually share the challenges and the successes from different clinics, from different provinces, and this motivated the health workers to a sort of like mini competition was put into place to see who would be best in which province would the maternal mortality and the neonatal mortality be reduced the fastest, and that incentivized the health workers.
Thank you. And we will be working with the toolkit and also, in terms of that, those metrics, the KPIs, and how we, implement. And I'd like to turn it over to Dr. Muhammad, who heads up the Division of Disease Control and Prevention for Africa CDC, in terms of, we've discussed, decreasing the maternal mortality by developing that sustainable, cost-effective response within the existing structure of the health system. I know we've had several conversations now, and, we are going to move to that task force, as John said, or this informal advisory group from this session for deployment. Could you give examples of potentially how we could, focus on some specific achievements using midwives in that healthcare ecosystem?
And thank you so much. For Africa CDC, the example that just come to mind is the one that we've been doing to respond to COVID-19. We asked ourselves, does it make economic sense? Can it take care of some of the challenges we've seen with COVID response, such as vaccine hesitancy and inclusiveness, And then is it aligned with the African Union Agenda 2063? So what we did at the onset of the pandemic was to set up a community health worker program, which can easily also include midwives. And the whole process started with looking at what countries are doing and knowing fully well that we'll be in this pandemic for the long run. And when we consider a country like Nigeria deploying epidemiologists to respond to COVID-19, spending about 3,000 USD per month, and then we were able to deploy community health workers to do the same thing and spending just about $100 per month. It makes economic sense. And like we've said earlier, using midwives and community health workers to do this work will help reduce hesitancy, because they are trusted members of the society and will be able to get acceptance easily in what we do. And that's exactly what we noticed when we deployed well over 18,000 community health workers across over 25 countries on the continent in Africa. So we were able to understand that this also makes economic sense, and it's acceptable. And what was the outcome? In the end, the deployed community health workers were able to reach over 2.5 million households for risk communication and community engagement, active case search and contact tracing. They identified over 1.6 million contacts and facilitated the test referral for over 78% of these suspected cases. So how did we do this? We were able to set up a task force within the Africa CDC HQ, comprising of the Director of Africa CDC and his key members, where we were able to really use existing protocols and work with other members of the bigger African Union to develop a system to deploy all of these community health workers. Then we set up a technical working group that comprises of member states, partners to coordinate this process and ensure that we are able to harmonize all of the things we've been discussing for the past 1.5 hours. How do we get compensation for these deployed community health workers to ensure that they are not just working and not being compensated? But again, that comes with accountability. How do we ensure we get accountability from them on what they are doing, and how do we begin to standardize this process and have an acceptable general for them all over across different parts of the continent? We did this in the task force with member states and partners. Partners have been working in this area for very long. Last Mile, Living Good, and Finance Alliance for Africa, UNICEF, AMREF, and CHAP. And we are still working on this. Some of the subgroups that we have are looking at some of the very critical discussions you're having here, like finance and sustainability of what we are doing. How do we ensure that the good work the midwives will be doing will be done in a sustainable fashion and not just a flash in the pan? Then, of course, engaging with member states, we had a subgroup, and then very importantly, the M&E group that will be looking at your KPIs and be able to document that, and then finally the policy and guidance subcommittee. So Africa CDC did all of that, and we're still doing it, working with partners, and we feel community working with midwives is a natural extension of what we've done in this regard. Thank you, and over to you.
Thank you, Dr. Muhammad. And as we discussed, we'll be working hand in hand, with you in terms of that deployment of increasing the number of midwives, and the deployment of of the different interventions, because I think as I said earlier, as a woman and, having started my career in Colombia and delivering babies, I think it's a shame when midwives don't get paid. And I find it unacceptable when, we deal with some governments that they still think that it's okay not to pay midwives, including donor governments. So we'll be working to make sure those midwives are getting those payments that are well deserved, and that we're scaling them to become their own entrepreneurs. So thank you. And I'd like to turn it over to Liz. I know that personally, in some of the delivery of medicines that have been done, throughout the years, you've worked on, creating that access, access to not only, female, communities, but then also in terms of access overall. So if you could share your thoughts on, how we, expand some of the midwifery programs, and over to you, Liz.
Well, hello to everyone, and thank you for joining us all here today. I don't even know where to start. I was jotting down some notes from what everyone was commenting, and then it became like a couple of pages long. But John, good to be with you again, and I agree. We are human. We need to be together, embracing and really driving these solutions. I love some of the comments I do have to make, right? Midwives don't just deliver babies, and I think we need to change that concept, because most people around the world and even in the countries still think about midwives as only delivering babies, and they are in a unique position in the home with the family, bringing a human into the world, and in the communities. They're so trusted and relied on. I think it's important, Dawn, you mentioned, we can't just recognize their role in the health system to clean up when it's needed and then say goodbye. How do we incentivize them in addition to recognizing and empowering them with pay for the work that they do, right? A lot of the comments made me think about something we hear all the time in an expression or joke format, and a couple of them are, you give her a house and she'll make you a home. You give her some groceries and she'll make you a meal. Let's empower, recognize, and provide them with the tools that they need. These women will transform and fortify the front line of the health system that is so greatly needed. Joanne, you focused on me in terms of the medicines and bringing the medicines. COVID has taught us all so much, and not all good. And yeah, we've been able to get medicines to the countries. A lot of companies do that. But our goal is, how do we drive health impact? And how do we make sure that those medicines get to the people? They're not all patients. A lot of our medicines are for people to prevent them from becoming patients. And that's where, I am encouraged by the conversations and a lot of the initiatives that we support, that will drive that integration and decentralization to get the medicine to the people, and some of them are already, unfortunately, patients. We strongly believe in that primary care network, empowering midwives. Yes, Fran, I was excited too with all of the conversation around really driving and, just seizing that moment with the midwives that, are here, and we can help develop so many more. So yeah, empowerment, training, deployment, and integrate and decentralize. Appreciate the opportunity to comment, and I look forward to building that advisory board, hearing from those who have shared some specific examples that were measurable. I mean, that was very, very encouraging. So thank you.
Thank you, Liz, so much. And I know that you have worked with John from Africa CDC in the past, and we look forward to getting the group of partners again, as we move forward to this. And I'd just like to, our live stream audience has been like jumping off. We have over 3,000 people. So just turn it quickly back to Ikuyu. I know that your comments started with homegrown solutions. Now, as you've heard the partners, in terms of, those framing of the discussion, and I know you're going to be investing in those local businesses, and we'll be working with some of the partners here for that deployment into those local healthcare businesses into Africa. Is there any other words of advice that you'd like to offer for the panelists in terms of our deployment as we're moving into next steps for country selection and the different pilots to deploy?
Thank you very much. Listen, I think really, I really enjoyed all the things that the panelists have said, and I really agree that we need to join our hands together to increase the number of the midwives and nurses, and then also the improve their skills, and then how to retain them in the position. I think it is really important. One of the things regarding to the increasing numbers, I want to share one experience from one country in Africa. They had a program to establish midwifery schools in rural areas with the intention to increase the output of midwives, particularly from the rural areas, recruiting the women from rural areas so that they can be there in their own community. But in the rural areas, sometimes it was difficult to find the qualified graduate, the secondary school graduate women, girls, who can be really qualified to enter into the midwifery schools. So I think there might be a need to link what we are doing in the improvement of the education system, like a secondary schooling and the quality of schooling, with the more specialized training, like the midwife, like institutional training for midwives. I think so that might be something that we may need to think of. Another thing is that the many people talk about the retention, and I heard Hillary mentioned about the need for the welfare and the work environment, and also Muchaneta. I'm sorry if I'm not correcting me pronouncing your name, but mentioned about the importance of involving a community. We also had the good experience of working with the community. Like when we support the community health workers, we also support the communities so that they can come up with, this is an example from Ghana actually, come up with what they call a community health action plan, a chat, so that that they can think about how they can really support their own health workers. Like some of the communities decided to fetch waters regularly, or the cut grasses, or some of the communities decided to deploy night watches or the guardmen, because many of the health workers are women, and then they have a security issue. So I think this kind of recognition and support from the community is also really important. And I think many solutions can be found in the community. So I think the two things that I want to share. But this sense of community, I think we may be able to expand it to digital community in recent, because if you go to Google Map, and if you click on the health facilities, you can find the many like a customer review kind of a comment. And some of them are, the appreciative of the service they get, but many of them is really like harsh on the health workers, how they behaved badly or things like that. But I think it is, to some extent that may express the situation or the experience of the users of the service. But I feel also like sorry for the health workers, considering the situation they are in, because they are little supported, and then they have to take care of many patients coming in, so there's little time to spend on one patient. So I think this kind of attitude in the digital world may be really kind of discouraging to the health workers, and you can like encourage more like the positive feedback from the digital world. I think that might also contribute to the more motivation for the healthcare workers. Yeah. So those are the things.
Thank you, Ikuyo. And I think you're singing to a lot of the work also that Phyllis has been doing on that secondary education. And I know at the center, you know, we work closely with USAID, and they couldn't make this session, but they will be part of the informal advisory group and kind of move forward in some of the help. But, you know, they deployed a $250 million fund that we helped them to create for basic education. And as you said, that fund was created solely because there is not enough girls going into different professions such as midwifery. And so we need that. And I know, Fergus, through Crown Agents, you talked mobile technologies, and I know there's a lot in terms of, you know, the mobile technologies that are being deployed to that last mile. So Fergus, I don't know if you wanted to add anything there in terms of some of the interventions that could be used.
Yeah, so thank you, Joanne. So I commented earlier that one of the things when I went out to see the results-based finance program in Zimbabwe, I was really fascinated by the fact that these kind of mobile health handheld apps, so it's obviously quite easy to get the quantitative data that's already out there from great work by the World Health Organization and UNICEF and others, but it's the qualitative data to get directly to hear from patients as to how they felt effective was that particular screening and the treatment, and to get that direct feedback. So that was wonderful. And then to see all of that data being used so quickly to then convert into these incentive payments was really strong. So that's positive. But I just wanted to say that all I'm hearing is that we've got the kind of data, the track record, the partners. There's significant money out there currently. And then obviously we have got the burning platform that COVID-19 has shown us, that we do need to come together quickly. And when something has been proven, then we can take it to scale. Now, it's not ideal, and the kind of real world meets some of the ambition, but I do really feel positive about the breadth and the depth of people that you've pulled together on this call for the advisory panel, as I do think we can go fast with this. So I'm very, very upbeat, Joanne.
Thank you, Fergus. And I know you and will be one of our work reviews as we move forward in the deployment of this. And Harold, just like to briefly turn it back to you in terms of, you know, some of the partnership that you've heard here. I know you're big on local government ownership, but just some additional thoughts that you've had as you've been listening to the speakers.
Yeah, I mean, let me just stress again that local ownership is indeed important, and an important element is also to have financial independence of health workers, female health workers. We can only be, as global donors, as private sector, we can only be catalytic in the long run. And I myself wonder, and I have not found the holy grail to this, I myself wonder what kind of business models around prevention do exist. I don't mean preventative medicines here, I mean prevention as a service and as an awareness. So I'm keen to explore that and to find common metrics in collaboration where we all have some skin in the game to this. I agree to 99% what Phyllis has said earlier. There's one tiny thing which I am not 100% aligned with, and that is it's easy to measure. It is when it comes to service delivery, when it comes to outcomes which are not linked to new buildings, for example, or to the number of midwives deployed, then it is actually quite difficult and resource intense. So we should not forget about finding the right theory of change, which we need to deploy. When it comes to training, then the question for me is what is the change in behavior, and what does this behavioral change lead into? When it comes to vertical transmission prevention, it's not just the mothers that have been screened and potentially put on treatment or the first doses are being applied, but also how many of the potentially at-risk babies have been born disease-free. And this is more tricky because ultimately you oftentimes need a baseline, and you need to invest and resource deploy into this, not just in monetary terms, but also using experiences. And I like John's earlier example on the two private sector partnerships, which were based on resource and knowledge deployment rather than on just funding. Thank you.
Thank you so much. And I think, you know, on that local ownership, you know, John, we will be working with you in some of those many roles as, you know, you help us to kind of lead this task force forward. But just wanted to get your thoughts before we moved on to one more speaker from the local perspective.
Thanks, Joanne, and I'll be very brief. Mohammed, I just want to recognize the very insightful and thoughtful comments from Mohammed Abdulaziz from the Africa CDC. Those are really, he has been an extraordinary champion and a leader during this time of crisis at the Africa pandemic on the continent, and with Africa CDC at the forward of fighting this. I think deploying 18,000 community healthcare workers speaks to the fact that it can be done. Okay, in a very short period of time, And as Mohammed would tell you, when we started that concept, I don't think even he himself believed in the power of that delivery. When I first started talking to them about the community healthcare workers, they were looking at me like, where is he coming from? But I know that in my previous jobs, I have used that. But there are two things that I would like to leave you with here is that, as I think Herad said, the measurability of what we do is very important, because what is going to be the driving factor in all of this is the KPIs and measurabilities. I mean, what gets measured gets done, and what gets done is supported. I think as we conceive this, we just keep that in mind, that has always been the cornerstone and centrality in guiding my public health practice over the years. And I think trying to quantify that and measure and count what is countable and what matters is going to be key. The last thing I would like to say is that we have to really frame this in the true spirit of partnership that is targeted at achieving certain things and using the crisis of now for this to matter, so that there's a saying that the rising waves raise all the ships, and now we have to take lament that COVID is here, but let tack on the back of COVID to try to beat it off, but then use that also as a legacy to say that we took advantage of this COVID and then expanded and implemented a midwife program that helped in solving the problem, but also was extended in solving other problems in the community. So I thank you again. Unfortunately, I have to run back into my other meeting on global health inequities, which we're all dealing with the same things here. So thanks, Joanne, for inviting me to be part of this discussion.
Thank you, John, and we look forward at the center to working closely with you as you move forward into, your many roles, and then also, to deploy this initiative. So we will be working hand in hand with you and how we deploy this initiative. So thank you. Thank you, John. And with that, last but not least, I'd like to turn it over to Olive, because I think, a lot of the country perspective, and I know you've been working closely with the commissioner, is important in our deployment of the efforts. I know we've done a lot of, calls with the commissioner in Uganda, looking to be one of those countries potentially that, goes within the first phase, of implementation. So Olive, if you can give us some thoughts, on, what we need. I know the commissioner is having some issues joining, and in terms of, how we can move some of these programs forward within phase one.
Yeah, thank you very much for giving us this opportunity as Uganda to speak on the issue of really promoting the development of women as service providers, really in the total health as we look at it. Specifically looking at the role of midwifery in Uganda and how services are being offered, and the need to really put a lot of emphasis on the development of the midwifery profession in Uganda. It's important when you look at the service provision in Uganda to appreciate that currently most of our midwives, and somebody else did mention it, many midwives are in the urban setting. And we find that for the rural women, they do not have the same level of concentration of the trained midwives in Uganda. Actually, we estimate, because our current level of deliveries in health facilities is about 73, we estimate that we have over about 30% of women not accessing services by a skilled provider. And yet, the Uganda government really has a long-term commitment on providing quality maternal health services. Therefore, as a country, and as some of you may have heard, we have been tasked with making sure that we are meeting the constitutional obligation of the state to uphold the rights of women and fulfill their reproductive health rights and needs, and prioritize therefore provision of sufficient funds to the national budget to ensure that maternal health care is really a priority. And the government of Uganda, therefore, through the Minister of Health, has directed that we are going to ensure that all the service providers that are providing maternity services, reproductive health services, are really fully trained up to the lowest level of care where the midwives are found. And that resources really have to be put aside for financial year 2020, 2021, and 2021, 2022. Now, this is going to take a lot of effort and a lot of advocacy on the side of the government to look for the necessary resources required to make sure that these midwives are capacitated and trained to offer these quality services. The good thing is that for Uganda, really, the midwives are trusted. They're invaluable to the system because we've had a long history of midwifery practice in Uganda, and definitely at the level of primary health care. They are very, very important over different types of services. They are not only catching babies, as one of the colleagues said, they are doing so many other services within the primary health care concept. And you may have read in other reports that Uganda has actually a deficit of midwives because our population is growing very fast, at 3.3%. We have a gap of about 30,000 midwives. And we would like to quickly put up programs that can ensure that we skill new ones, but also we retrain, retool those who are already in service.
Yeah, and that's
the government of Uganda, is committed to increase this number, preliminary with a focus on efforts to impact on maternal health, but also the preventable diseases that are so many, including those which are vaccine sensitive, because midwives actually do this kind of service for Uganda. And if we can promote them, we'll be having a big coverage, especially for the rural man. Back to you, Chair. I think that is in regard to really, are we committed? How are we working to ensure that will be noted that they are alone as they are only in the public institutions? As you heard earlier from the representative of the Protestant Medical Bureau, we government has recognized that almost half of the services in Uganda are either offered by the public health institutions or they are actually by the faith-based institutions. Therefore, it is going to be very critical for us as we develop this profession further to know that we are dealing with both the private for-profit and private not-for-profit, including NGOs. We are having many associations. We have, for instance, the Uganda Private Midwives, who are also advancing provision of midwifery care in Uganda. So we are going to take an approach where we do want to increase the cadres that actually provide skilled care, but recognizing that, yes, we may have another level at the community level, which we will have to work with, which will promote, which will be working with midwifery. We have, for instance, community health workers and the village health teams, but we also do have traditional birth attendants, and there's a part that is now being streamlined for them to be able to participate in the delivery of midwifery services. So for us in Uganda, there's going to be a great need to invest in the education institutions. We need to make sure that these health workers are using evidence-based materials and that they are being trained by the most trusted institutions. We want to be able to support these different cadres to have better skills. And of course, we want to make sure that both government, private not-for-profit and the private for-profit are part and parcel of this service delivery in Uganda. And we at WHO, because I'm the WHO Office for Reproductive Health, we have been working and will continue to work with the government to ensure that what needs to be done to promote all institutions delivering midwifery services in Uganda is actually being done. And we would like to see that the midwifery practice is supported, their environment is promoted in terms of skilling, in terms of equipment, in terms of skills labs, so that we are able to improve on this side, which is so important for the survival of women and children in Uganda. I would like to apologize for Beatrice, the commissioner, who has had major difficulties with the internet, but she was also suddenly called to answer another call. So I really apologize. I hope she would have said what I've managed to deliver, the government perspectives on midwifery. It's a key area of work for us and would really support whatever is going to be done in this project. We welcome all the efforts. Thank you very much. Olive on behalf of Beatrice, the commissioner.
Thank you, Olive.
Thank you.
Go ahead, Anthony.
Yes. Alice, thank you so much for filling in for the commissioner. We did miss her, but we really look forward to working with her and the Ministry of Health as we develop this and we deploy this, this great initiative. We have been reminded on several occasions, you know, the importance of government and how necessary that is in order to ensure that these programs actually get off the ground. So thank you very much for filling in. I'd like to go to Dr. Michael Reed right now for some comments. Michael, we've discussed on several calls the need to truly empower midwives, give them a sense of support, to give them a sense of worth in terms of what they do and how they do their job. I know you spent time in rural hospitals working alongside these incredible caregivers. So if you wouldn't mind just sharing some of your thoughts on how and why we should empower these caregivers and the crucial role they play in the entire health ecosystem, that would be wonderful. Thank you.
Great. Thanks. Thanks, Anthony. Yeah, I think, you know, I'll just start off by saying that if you're going to have a rural health center that is going to be manned by a healthcare professional, or in simple terms, a nurse, it's going to be a midwife by option. That's your first option to have. And this is what we've experienced, that we're having midwives leading institutions, leading rural health centers, and not just providing for maternal care, but the whole spectrum of care at these rural centers. And so, you know, when you see the impact to the community of having a person with that level of skill, of course, being extended beyond, as I said, maternal care, you have community that would have been super underserved, getting an opportunity to get some service. So, I've just been thinking along the lines of, key phrases that have come today around, let's train, let's incentivize, let's retain, and there's something that clicks into my mind. We're looking to train, train and incentivize to retain midwives. And if we are happy and we can see midwives running institutions in rural health centers, in a similar way, midwives can lead and run institutions in a private setting, right? And we have seen this, and I like the Uganda example that's been given of the Private Midwives Association. And we see this too coming up, in Zimbabwe, where they're really looking and saying the impact of midwives is so huge that we need more of them on the ground and available to all patients, right? Bring in the diversity. We've got a private healthcare system, we've got government, we've got a missing middle where people can still pay for services, but maybe can't afford the super private, but they would be able to gain from a midwife-led continuity of care institution. And in the similar way that we see and that I've experienced working directly in some of the rural institutions and hospitals in the countries that I've worked in.
Thank you. I see that we still have Dr. Muhammad with us. Dr. Muhammad, I see that we're over time, and just wanted to really emphasize some of the programming that I know that you're going to be doing and working with some of the stakeholders here. As was mentioned before, those KPIs, but I know that you also have some programs that you're really focusing on deploying. I was wondering if you could comment a little bit to some of those programs as we're looking to scale the number of midwives with the specific programs and potential countries that we can work with. And I don't know if we lost Dr. Muhammad.
No, I've had to step and to be on my way back to an engagement. However, thank you very much. Most of the programs we're running in Africa CDC for scaling up health workers' involvement in is housed under the technical working group that I told you about earlier on. However, looking forward and trying to be sustainable with
I think we lost Dr. Muhammad.
Created right in the middle of the pandemic, a unit that, hello, can you hear me?
You're coming in and out, but we can hear you a little bit now. We can hear you.
So a new division created at Africa CDC, the Division of Disease Control and Prevention, is to house all of the programs that is aimed at increasing the community health workers and other health workers' involvement with response to public health events and other form of health system strengthening, looking at sustainability. How do we ensure that the programs of Africa CDC contribute to the aspiration of the head of states, which called for 2 million increase in health workers on the continent, especially community health workers and the likes of midwives, collectively to ensure improve health indices on the continent. So basically what we'll be doing at Africa CDC is to transition between the rapid response we did for COVID-19 and then institutionalize it in a division of the Africa CDC moving forward that will now ensure that we have to intervene in the areas of improving access to and of course the work of the community health workers and midwives in throughout the continent of Africa. Thank you. Over.
Thank you so much. And then last but not least, also I see Christine, you're still with us. And I know we talked briefly about the user-based model, but Christine, I don't know if you can add, I know you will be doing a one-on-one calls with the partners to follow up on the specific modeling, you know, anything else to add from Ugandan Protestant Medical Network?
Thank you very much. I'm very privileged to be in this meeting and to learn of the experiences from different places. So for us at Uganda Protestant Medical Bureau, the key deliverables are really what has been shared, which is to improve the staffing levels of health of the midwives in the network, in the UPMB network, focusing on the lower level health facilities, and then of course to improve the skills for midwifery cadres by 25%, and we look to do this at and improve the sustainability of midwives, focusing on the different health financing models that we implement. One, which is the result-based health financing, to scale them up, because currently we work with the Ministry of Health to implement the result-based financing model, but only in 2 regions. So if we could scale this up, because we have the different training institutions all over the country, as Dr. Hilary had shared, but also we have the community-based health financing schemes that we implement, which is also a kind of result-based health financing, but focusing mainly on the entire services at the health facility. And this is a unique mechanism that helps the communities to work with the health facilities to improve on the quality of services by pooling resources and bringing to the health facility, but also helping in access of the healthcare, especially the primary healthcare, and the maternal and child health care. So we feel that there's a need to have the team that can work, and those are the midwives in this model. So increasing these models and scaling them up, because currently we stand at about 16%, but we would love to expand it, because for sustainability, really, this is one of these are the mechanisms that we feel that UPMB can promote, and can promote the midwifery services. And of course, we also look at working with governments in the primary healthcare funds to recruit and posting of midwives. And also providing mentorships for the midwives in the rural areas. This is through a hub and poke model. So this is a model that that helps in bringing mentorships for the rural midwives. Yes, thank you very much.
Thank you so much. And I know we are way over time, and I'd love to have additional time for each of us to speak, but I know that we'll be working with each of the partners, WHO, on the deployment of the toolkit, the Crown agents with the results-based financing, working closely also with Gilead in terms of the access to medicines and a lot of the lessons learned and experiences that they have there in terms of deployment, and also have been working closely, in terms of the implementation also in Pakistan, and then closely with, Africa CDC and a lot of the partners, JICA. And we'd like to, I know Megan is still on. And so, they will depend on some of the networks too of women investors and philanthropists that, that will be also deploying capital into this. And I see Phyllis back in terms of the leadership too, with the UBS Foundation, all those education programs that are necessary to get women there. And so, you know, I'd really like to thank our speakers and thank them too for you know, agreeing to move forward with, you know, the deployment of the programs, because, you know, we have the programmatic you know, implementers here that have spoken about some of the ways we can move forward, and also with those clear KPIs that are needed, and how to move forward. I'm going to give you just 30 seconds. I'll start with Phyllis, and then give it to Ikuyu, Fergus, and Harold, Megan, and Fran to say some concluding remarks, and Liz, so that we can finalize. And our live count is over 5,000 right now. So I'll turn it back to you for some quick concluding remarks of 30 seconds.
Well, thank you everybody for listening in on this. I think it's been a really important discussion. And Harold, I'd like to come back and take that point about easy. When I said it's easy to measure, you're right, it's not that easy. The reason I said that though is because at least we have a lot more evidence in the healthcare space about the benefits of midwives and female community healthcare workers. So we know that healthcare is going to be better. And I would urge everybody on this call to do whatever you can to finance this important movement, because we need it for our communities and to prevent and mitigate the harms done by this pandemic and future ones. Thank you.
Thank you, Phyllis. Fergus?
Well, thank you very much. Thank you very much. So it's getting late here, so very quick. I really appreciate the importance of partnership. So, and I really looking forward to working with all of the people here, and see you then.
Thank you, Ikuyu. We'll be working closely with you, Fergus.
Yeah, I was just going to emphasize partnerships, data, and the ability to replicate what we've already got working. It now feels the time we can bring all of that together, and it's really exciting. So thank you so much, Joanne, for pulling so many people together on this really rich call.
Thank you, Harold.
Yeah, thank you. I mean, I initially mentioned integration of care, and the integration that happens when we from different perspectives join for such a communication conversation is just amazing. And I hope we could really move closer together via the advisory group, but also in practical terms to identify what are we going to do, and who is accountable eventually for what aspect. Looking forward to that.
Thank you, Harold. Fran?
Well, I think as a midwife on this call, I'm completely blown away. We are advocates for women's rights as well as providers of care right the way across women's lives. And I think if I could have other midwives hear what has been said on this call today, it would be fantastic. So I would really like us to remember that midwives do more than just support women in birth. There is no primary health care without a midwife, and that message has come across loud and clear. As WHO and as Olive said, and Beatrice would say, the Ministry of Health in Uganda and many other countries are 100% committed. We know what to do. We have the tools and resources. And I think if we can really come together in partnership to make this happen, we will save so many women, newborns' lives and change societies in many, many ways. So I'm really looking forward to the follow-up conversations and to move it into the country level where we all love to actually get on with things and see those changes being made. So thank you very much for everybody today.
Thank you. Dr. Hillary?
Thank you very much, Joanne. I think it's been a lot of rich experience sharing here today. And indeed, we do look forward to the partnerships. And for the case of Uganda, definitely to save the lives of mothers, to improve the lives of midwives, but also basically to improve family stability in Uganda, because we know the effects of losing mothers on homes and on the girl child. So when it goes a long way in affecting communities. So we're really looking forward to this partnership to improve that for Uganda. Thank you so much, and to everybody too.
Thank you, Dr. Hillary. Liz?
Listen, great health drives strong communities, and that's what we want to be a part of. And who knows, we might even be able to shift some social norms related to their value. So let's get on with it, as Fran says, and seize the moment, as John said before he left.
Thank you. Olive?
I think we have a great opportunity in this partnership to really ensure that we are addressing the whole big profession of midwifery in Uganda. As WHO working very closely with the government of Uganda, Ministry of Health, and all NGOs really and individuals promoting midwifery. This is an opportune time for us, and we are ready to work with this partnership and ensure that we reach the most rural health facility that we need to see a midwife in. For Uganda, it is really welcome to be working on such a big partnership that will put the life of women, the life of children, the life of men in the hands of midwifery, in the hands of the midwives, and the more support we give them, the better the way we shall be able to increase universal health care in Uganda. It's a correct investment now. Thank you.
Thank you, Olive, and thanks to everyone. We've been on a lot of calls prior to this session. We'll be on a lot more afterwards, but thank you everyone for committed. We are really excited about this partnership, and we're more excited for this than the previous funds that we've raised in the past. This is real deployment on the ground, so we'll be working with each of you in that informal advisory group moving forward closely with WHO, UPMB, all the partners, JICA, Gilead, UBS, Crown Agents, and Megan as well. And we really are looking forward to it. And I wanted to thank you so much. And over the next few weeks, you'll be hearing from us. So thanks a lot.